Okay, so now that we're recording, welcome again. Our topic is obviously body-focused repetitive behaviors and OCD. When this topic was proposed and then voted on by you, what the gist of the topic was, this is not how it was formulated in the poll. It was just the shortest title that I could come up with. Essentially, what you wanted me to discuss is similarities and differences between these two, and also to talk a little bit about the neurobiology of both. And I've had requests for a webinar on neurobiology of BFRBs before. It's just that I don't think there are studies here and there, but I think it's very hard to come up with a coherent model and present it to you in that way. So I took this opportunity to address this topic because when it comes to OCD, there's quite a lot of research, and then we can discuss what's similar and what's different. And I will try to make it as kind of simple and palatable as possible. As I already said, you have my SkinPick email, so you can email me with any questions later on. So this is what we will be talking about. First of all, we'll talk about what OCD is. I framed this in a way that OCD is kind of in the forefront, because most of you that are listening to this, you don't need me to explain what body-focused repetitive behaviors are. We have had basic webinars on this topic before, and I know that most of you, since you struggle with BFRBs, already know what it is. So I will be defining OCD and telling you how it's diagnosed, and then we will compare it with BFRBs. So that's how we'll do it. We'll take OCD as our starting point, and then we will go on to talk about where it overlaps with BFRBs. We'll talk about OCD as a spectrum and what that means for body-focused repetitive behaviors. And then we will talk a little bit about the treatment options and causes of OCD and BFRBs. We will, of course, mention genetics because it's hard to run away from this. This is something that people frequently ask about. And then, as I promised, neurobiology. But to start off, we have to start from the beginning. I don't want to go into a detailed history of both BFRBs and OCD because that would be a fascinating topic in itself, I will say. No one's ever proposed it, so we've never done it. I will start with how we got the name, and I will have to start with him. You all know that guy. So from Freud. OCD, although not under that name, was studied before Freud, but our contemporary understanding of OCD and the name OCD comes from Freud and his case report about what's famously known as the Rat Man, which is a patient that Freud worked with, and he got this rather absurd nickname because of a dream where rats figured in as an important element. In fact, I guess we could say that the history of OCD and psychoanalysis really do kind of connect at this beginning, because incidentally, this was also the first time that Freud presented a case that was successfully treated with psychoanalysis. And the way that he titled the case was Notes upon a Case of Obsessional Neurosis. And that's how we got the name OCD. Of course, as everything that Freud ever said, thought, wrote down, mentioned, quoted, everything, all of it was quite criticized. And this case is no exception. Except that, so there is, let's say there are legitimate and less legitimate criticisms. What you see here on the left are parts of Freud's original notes from therapy sessions with the Rat Man. And then some researchers have compared Freud's actual published paper with the notes. And apparently he took few too many liberties when he formulated the paper. So that would be one criticism. The second criticism would be that he didn't actually heal the man from OCD, even though he said the treatment was successful. I find this to be a rather absurd piece of criticism, considering that no other form of psychotherapy has done more than what he has. So it's very rare that you see someone who finishes their treatment with OCD and then do not experience obsessive thoughts or compulsions ever again in their life. we usually talk about managing it, right? So, but Freud is kind of a polarizing figure, so all these things will come up. But this is where it all starts. Our contemporary understanding of OCD and everything afterwards starts with him. I decided to start this off by talking about Freud because I think he gets a lot of criticism, and frequently rightfully so. But at the end of the day, even today, with all the advances that we've made, we still speak the language that psychoanalysis has invented for us. So I think we have to pay certain respect to, at least because of that. So this is where a kind of more scientific, even though a more scientific interest in OCD began, even though I guess it would be a bit of a stretch for our contemporary understanding of science to say that psychoanalysis constitutes a scientific theory, right? But that was Freud's intention. So this is where it all started. When we talk about OCD today, we're talking about something different than we talked about even when I went to medical school. When I went to medical school, that was before DSM-5. And so OCD was considered at the time to be a kind of an anxiety disorder. It was classified in that category, whereas now it is no longer considered to be that. Obviously, anxiety is a symptom that is very much present with OCD, but because we have learned so much about it, we now know that it's not a subtype of it's not just one more anxiety disorder. When we talk about OCD, we're talking about a combination of at least two, let's say, two classes of phenomena. So on one hand, you have intrusive thoughts, and these intrusive thoughts produce quite a lot of discomfort for people who experience them, a lot of anxiety, a lot of threat, dread, and so on. And then you have all these compulsive behaviors or rituals, which are employed for the purpose of alleviating the discomfort that the thought caused, or to make the thoughts go away. So these rituals may be very private, meaning that only the person knows about them, or only the person who has OCD does them, but they can also involve other people. So sometimes in certain cases of OCD, it's not enough that the person does something, but also those around them, right? The rituals, as this definition here says, are really there to compensate for the ego-dystonic feelings of the obsessional thoughts. Ego-dystonic just means that they don't feel like they're yours. When something is ego-syntonic, it feels natural to you. When something is ego-dystonic, it means that it feels like it's external to you, coming from somewhere else, not you, not a part of you, right? So when it comes to obsessive thoughts, they don't feel like they're your thoughts, but they just kind of intrude into, they kind of intrude into your awareness, right? And then they cause a significant decline of function, this combination of rituals and obsessive thoughts. I will say that this part is extremely important, which is a significant decline in function. The same thing is also included, which you probably already know, in the definition of all body-focused repetitive behaviors, which is that behavior in itself, if it causes no harm, isn't necessarily sufficient to diagnose someone. It has to cause problems in how you function in your everyday life. In other words, you have to recognize it as a problem, right? In DSM-5, which came out in 2013, OCD is no longer like it was when I was in medical school, an anxiety disorder. In fact, it became a disorder in its own category, which is obsessive compulsive and related disorders. So now we're talking about a broader spectrum of disorders, right? So some of these that fall into this category are obviously OCD itself, body dysmorphic disorder, hoarding, and then BFRBs, such as skin picking, which is our primary topic, and then also hair pulling. I will, when I'm presenting later on research, I will present research that pertains to both skin picking and hair pulling, because that way we have a bit of a broader range of studies to draw on. Because if I just split it up into skin picking and just present this, I would quite literally have, I could count on probably on fingers of my one hand, just how many studies I would have to present. So we will take a look at body focused repetitive behaviors as a whole and their relationship to OCD. So I'm quoting here from this paper down here. You can find the paper for free online if you wish to read it. So the paper says the following: it has become apparent that these disorders meaning those from the OCD spectrum, so all the ones that I just mentioned, can also be viewed as being on a continuum of compulsivity to impulsivity, characterized by harm avoidance and the compulsive end and risk-seeking at the impulsive end. So on one hand, you have avoidance, and then on the other hand, you have risk-seeking and impulsivity. The compulsive and impulsive disorders differ in systematic ways that which are just beginning to be understood. And this is really the key. We don't have a comprehensive theory of them. In fact, I would say that as far as OCD goes, like you have Freud, for example, had his idea that OCD was related to certain sexual or aggressive impulses that have been suppressed and then come out through compulsions. You have other theorists giving you other psychological theories. You also have quite a few findings when it comes to neuroscience, but there's really not one unified theory. Even if you're more on the psychological side of things, or if you're more on the neuroscientific side of things, you really don't have just one thing to latch onto. And so I think it's really important to understand what I will present here as maybe an incipient theory rather than an actual model of anything. But what is important to understand is that when it comes to the OCD spectrum, we're not just talking about excessive anxiety like we do with, let's say, generalized anxiety disorder, right? We're talking about either compulsivity or compulsive or impulsive behavior, essentially. When it comes to body-focused repetitive behaviors, avoidant behaviors are quite common. In fact, I guess plenty of you know that a good part of our treatment at SkinPick revolves around this idea that skin picking is a way to avoid dealing with certain private experiences, whether they are feelings or sensations or memories or predictions, whatever, anything that causes significant discomfort. So we can't really say that that is always the case for every person who has OCD, right? But it is one part of the spectrum. We also know that sometimes we can look at body-focused repetitive behaviors as being just certain forms of impulsive behavior, right? When the urge kind of takes over and then you act on it before you even have time to think, right? So it can also be seen as a type of impulsive behavior. So I like the fact that there is this concept of OCD spectrum for several reasons. As you will see when I talk about most common forms of OCD, it's sometimes very difficult to distinguish between what you could call normal behavior and then what would be OCD. And also within what we include in the OCD spectrum, they kind of overlap. So sometimes you will actually have people who have body-focused repetitive behaviors and OCD concurrently. And you will see that in terms of thoughts that precede the behaviors, sometimes it'll be really difficult to distinguish what belongs to OCD strictly as an entity and then what belongs to the BFRB, right? So when you think about it as a spectrum, the difference in the end becomes less relevant because we are talking about the same group of behaviors overall. So this is quite useful in treatment sometimes. And also the same thing that I said about OCD, the fact that sometimes it kind of tappers into normal behavior and that the boundary is not always that easy to establish. I think the same applies for body-focused repetitive behaviors, because a lot of the times culture plays a role in what we think of as normal, right? So in that sense, grooming first of all, grooming is also biologically normal behavior, and it's not just limited to humans. So other animals exhibit the same type of behavior. On the other hand, there are certain types of grooming that are culturally acceptable. And when you start getting into the details of every person's struggle with skin picking, sometimes it is difficult to ask this question, for some types of behaviors. Sometimes people will say, well, I consider, let's say, taking out my blackheads as being skin picking, but there are some pimples that when I pick, I don't feel like this is a part of skin picking. I feel like this is just regular grooming. So the line is not always very clear. And ultimately, in psychotherapy, we truly have the luxury of saying whatever science says, we can put it on the side. And science doesn't really have an answer to this. Whatever so society says, we can also put that aside and then see what actually works for you. Where is the line that you want to draw? What is actually normal to you? So this is why I love the idea of the OCD spectrum, because in therapy, it really allows me this flexibility to create specific milestones and goals in treatment with each individual client that I work with. I don't have to have a prescription that says, well, this is acceptable, this is not acceptable. It's acceptable as long as it's acceptable to you. And I also don't have to be overly concerned to differentiate these in every instance, right? So how do we diagnose OCD? Well, first we have to have presence of obsessions, compulsions, or both. What do we mean by obsessions? You need two things to define obsessions, two components. One, recurrent thoughts or urges. Sometimes they're also images, and they're not wanted. So these are not thoughts that you actually choose to think. These are thoughts that seem to come on their own, and thoughts that cause distress when they show up. The second thing that needs to be fulfilled for something to be an obsession is that you try, once that thought is there in your mind, that you try to somehow get rid of it, to suppress it, remove it, run away from it, or try to get rid of it with a compulsion, right? So if you look at the way that this is defined, you can clearly see that some of this really does resemble the urge to pick and what the urge actually feels like. It's not, some people will describe the urge exactly like this, and it will sound like an obsession. Whereas for other people, it's not going to be this experience. So this is where we see that partially it is similar to OCD, but also not always. Some people will also pick their skin without actually experiencing the urge. Some people will only have thoughts, and these thoughts might not be unwanted thoughts, and they might not even be experienced as what I defined as ego dystonic previously. They might be thoughts about work, thoughts that you're actively engaged in. So here we can already see that with this only one small part of how you diagnose OCD, there is also overlap, but there are also differences. The individual attempts to suppress thoughts, urges, or images with some other thought or action. This also doesn't always fit the mold of BFRBs. So sometimes that is true, but at other times, BFRBs kind of arise as a way to allow you to think those thoughts in a more peaceful way, not to make them go away, but to focus. This is something that I hear relatively frequently, things like, my skin picking helps me focus. So in some cases, this is absolutely true, but then in others, it doesn't quite work. Compulsions are also defined by two different points. One, repetitive behaviors or mental acts that the person feels driven to perform in response to an obsession. So a thought comes into your mind. It's an intrusive thought. It makes you feel very distressed, anxious. You sometimes might even feel guilty, right? Threatened, afraid of it. And then you engage in certain behaviors or mental acts, as they say. Although since I'm a constructivist, the difference between those two is not always also very clear. But the point is that you do a compulsion, something you perform as a consequence of an obsessive thought. And then the second thing is that the intention behind these behaviors is to reduce anxiety or distress, or to prevent some dreaded situation. So you might have to repeat something 5 times so that someone close to you doesn't die, for example, right? So there's also a caveat here. I cannot pronounce this word today. So that these behaviors or mental actions do not connect in a realistic way with what they're designed to prevent, or are clearly excessive. So the compulsion that follows from an obsessive thought is not realistic. You have to knock on wood so that you prevent something bad from happening, for example. This in itself might not be OCD, but when you have to do that 10 times, and when that's something bad is something as terrifying as, I don't know, causing an earthquake, then it becomes a problem. And this is what I was talking about, that thin little line. Because, for example, there are people who will pray, and they will truly be afraid that something bad will happen if they don't pray, yet we wouldn't say that they have OCD. But then again, there is such a thing as religious OCD as well, as you will see. So these are those little points where we have to be very, very careful how we name things. Except for these 2 things, so the presence of obsessions and compulsions, we have 3 other things that we need to fulfill in order to diagnose someone with OCD. Obsessions have to impair your everyday functioning. And this is also true for body-focused repetitive behaviors. If you sometimes pick a pimple, and this doesn't cause any distress, and it doesn't cause you to avoid certain social situation, doesn't cause excessive shame, doesn't actually alter your functioning in any way, then we can work on the behavior in psychotherapy, because we don't need an official diagnosis to do psychotherapy, right? Psychotherapy can be a form of personal growth, but unless there is significant distress, we're not going to say that this is OCD or this is dermatillomania, for example. We have to exclude effects of different substances or medical conditions, because sometimes medical conditions can mimic certain behaviors. So in literature with body-focused repetitive behaviors, we have connections between some medical conditions. Like one that comes to my mind is that there are certain cases have been described where hair pulling comes about as a consequence of anemia, not a psychological issue. And we know that, for example, when people have Parkinson's disease or Huntington's disease, that they will often develop obsessive compulsive symptoms as well. And in that case, these symptoms are consequences of these neurological conditions, and they are not OCD in the sense of a psychological or psychiatric problem. And there's no better explanation for the symptoms, right? So that kind of is commonsensical, right? So what are the most common obsessions that we find? Of all these, you might notice a few that actually overlap with skin picking as well. Starting with the first one, obsessions related to contamination, dirt, certain infectious agents, body fluids, and so on. So one of the things that OCD with contamination in my clinical experience, so I'm not talking about official statistics, but looking at my clients, this is the most common form that I see. If we exclude perfectionism, that's not necessarily always OCD, but can be. But contamination is also something that we see with body-focused repetitive behaviors as well, specifically with skin picking, because sometimes people will report that they pick their skin to clean it, or they pick their skin to get the bacteria out, or they pick their skin to get the dirt out. There's kind of an implicit theory that by picking their skin, they're getting rid of something filthy. So this is not exactly the same as contamination OCD, but you can clearly see the connection there. Sexual obsessions are also quite frequent, violent obsessions, scrupulosity. This essentially means religious or moral OCD. Identity obsessions, like questioning your gender or sexual identity, obsessively. So not having a genuine, let's say, crisis of identity, because as we grow up and as we develop, even as adults, we will question who we are sometimes. And this is fine and normal, and this is a part of being human. But when we talk about identity obsessions, we are talking about unwanted questioning. Like you feel like these questions intrude into your consciousness. It's not something that that feels like it has come out of your circumstances in your life or your own conscious choices as to what you will think about. Obsessions about responsibility, and then perfectionism. So perfectionism related obsessions, I would say that have quite a strong connection to body focused repetitive behaviors. We've had a whole webinar on perfectionism, and in therapy, I almost said we talk about perfectionism, but I talk with so many of my clients that I have conversations about perfectionism several times a day. And in our support groups, we've talked about perfectionist tendencies, who knows how many times. When there's only one way to do something and that way is flawless, so when it comes to body-focused repetitive behaviors, their role is not as a compulsion. So this is important to differentiate it, because on the surface, it may seem like a clear case of OCD itself. But sometimes with perfectionism, skin picking comes about as a way to alleviate the anxiety that perfectionism creates, but picking itself is not necessarily compulsive. I hope that distinction makes sense. If you have experiences that you're unsure of, please do email me and I can help you kind of differentiate between them, and I can help you figure out which one's which, or at least clarify the difference afterwards. Most common compulsions that follow the obsessions that I just listed include washing and cleaning, or if we're talking about skin picking, then it would be picking your skin in order to clean it, right? Checking, repeating, mental compulsions like praying, counting, preparing, and then arranging things in a specific order. You can see that here there's less of an overlap with in the compulsive arena. There's less of an obvious overlap with what we think about when we think about picking. Although you will very frequently say that you will frequently hear, if you're a therapist, that picking for people has to do with making the skin smooth and therefore perfect, or cleaning the pores. And then when you clean your pores, then your face or whatever body part looks perfect. So that there is some overlap there as well. Now we're going to go on to what I think of as a more interesting, more exciting part, which is to discuss what actually causes OCD and the reason, and also body-focused repetitive behaviors. And we will look at some very interesting and significant, I would say, areas of overlap. So the most honest answer that I could possibly give you is that we have no idea what causes OCD. In general, when it comes to mental health, it really depends on kind of the paradigm that you accept and the point of view from which you start. Reality is kind of elusive for most things. We tend to look at these at disorders from at least 3 different perspectives. We have something that's called the biopsychosocial model. So we will look at the biological component, because whenever you think, something has to occur in your brain. When you move your hand, again, something occurs in your brain. So even if something has a psychological component, it also has a biological one. So it always makes sense to look at the biology of things. Since everything that we do has an appropriate subjective component to it, there is subjective experience, there is our intention, what we want to achieve with that behavior, what its function is. So there's always sense in looking at the psychological component. And then there's also the social aspect of it. And by that, I mean cultural, but I also mean socioeconomic. I won't discuss that aspect here because we simply don't have the time to go over everything. But that is also an important component in a lot of mental health problems. Certain mental health problems are less likely, have to do with education, have to do with income, because all of these determine many other important patterns in your life, including access to healthcare, right? So it also dictates symptom severity. But when we sum it all up, we don't actually have one picture. The best way to look at this as a bunch of pieces on the table, but we don't actually know what is the puzzle that we're kind of assembling. So you will see a lot of findings that seem to be consistent and repeated, or that overlap between OCD and BFRBs, but the significance of those isn't necessarily always obvious, or frankly, even known to us. I usually, when I work as a therapist, and in these webinars as well, I have a tendency to downplay the genetic and the biological aspect of things. And this is for one simple reason. I like this. I enjoy reading the research. I truly do. I find it all very fascinating. But I think that there's a significant difference between how someone who's a researcher or even a doctor might understand these, and then how this somehow translates to people. So, for example, there are studies, quite a few of them, that show that OCD, in maybe up to 60% of cases, 65% is, I think, the highest number that I came across as I was doing the research for this webinar, they have some genetic component to them. We know this from because identical twins are more likely to develop OCD than non-identical twins, right? So twins that have identical DNA versus those that don't. So this tells us that there is something about the genes, but more likely doesn't mean that they will. So genetics might be one component of it, but it's certainly not the entire puzzle. We know also that parental or sibling OCD tends to be a risk factor for developing OCD. Does this mean that your parents give you OCD? Well, not quite. In fact, when you have, this is also something that we see quite frequently with body-focused repetitive behaviors. We see skin picking, for example, in one client, and then in a sibling or in one of the parents or one of the grandparents. Genetics is one way to explain this, right? But it's not the only way to explain this. If you talk to any family therapists, they will give you another explanation in a millisecond. They will say, sure, genetics might play a role, but at the same time, there are patterns that we transmit through families and through generations. We now know, because research has really kind of progressed quite a bit, and we have these really rather fascinating studies that talk about epigenetics and that show that certain behaviors or risk factors can be transmitted to future generations, but not by changing our genes, just modifying how they express themselves. Famously, you have those studies on Holocaust survivors that show that their offsprings are more prone to anxiety or depression, and sometimes, strangely, even inherit memories. We don't quite know the mechanism of this, and the research is really just getting started. But my point with this is to say that even if it runs in the family, in therapy, I don't usually overplay the genetic component, because I don't think it's the most pragmatic way to look at it in psychotherapy. Because in psychotherapy, our focus is on psychology. So if we can identify patterns, we can change them. If we say it's genetic, what exactly can we do with it? Not much, right? So in that sense, from a psychological perspective, looking at it only through the prism of genes is slightly limiting. Does this mean that they don't play a role? Absolutely not. So this may be kind of difficult to wrap your head around, but what I'm actually talking about is a pragmatic approach. We take that approach which works in a particular context. Now, when it comes to brain science, this is a different area altogether, where even when we talk about structural or morphological differences, so that when we talk about brain changes that we can measure and see, therapy still isn't powerless, and there is place for that there. So these kinds of studies, in my opinion, are more useful to look towards for psychotherapy, both in terms of planning the treatment and creating psychological theories and understanding how something happens. So we know that when it comes to OCD, genetics do play a role because of what I said about twins and parents and siblings. But the best way to think about it is that it's a risk factor. The same way that when you have someone with a history of heart disease in your family, and then you have a higher risk of having some kind of heart disease yourself, but it doesn't mean that you have to. For example, both my parents have very high blood pressure and take medication for it and have had quite serious heart problems. Both of my grandfathers died from heart attacks, but my heart is fine and I don't have elevated blood pressure, even though obviously there is a risk factor there. But because I know that there is a risk factor, I kind of live my life in a way to try to minimize stress and cope with it better. And I try to eat well and I try to exercise and so on. So thinking about it in terms of a risk factor means that you actually have space to intervene and that it's not your destiny. So that is the way that I would frame it. For example, we know that stressful life events can trigger OCD, but I don't think it's necessarily fair to say that stressful life events cause OCD. The same way with skin picking. You know that anxiety can trigger picking, or sometimes a fight can trigger picking, but you cannot say that your aversion to fights or arguments or discussions or your aversion to difficult emotions is the exact cause of your skin picking, right? You can just say that this behavior emerges following something else. So the same thing goes for stressful life events. For example, when the COVID pandemic started, I had I think 2 or 3 clients almost at the same time who came to therapy with different forms of OCD, some related to the pandemic, others not, but all triggered by it, because the pandemic has caused such a dramatic shift in how we live practically overnight that it was really difficult for some people to adjust. But can we say that COVID caused OCD? Absolutely not. But there was already let's say, there were already patterns of behavior and thinking in place that kind of worsened when COVID came about, and then that produced OCD. There are theories about strep infections and autoimmune reactions that happen afterwards, but this is not something that everyone would agree on. But it is possible for OCD. We have absolutely no evidence for it so far that I know of for BFRBs. When it comes to genetics, stressful life events, hopefully this is clear to you that it also works the same way for BFRBs. But when it comes to genetics, in the area of skin picking and in general for body-focused repetitive behaviors, it is grossly under-researched. So we can't really say much definitively. The studies that you have and the number of studies that we have for OCD, we don't have for skin picking or for hair pulling. I am acquainted with a few studies, and they usually have very small sample sizes. So that means that we can't really extrapolate much from them. And second thing is that they usually look at correlations, meaning that they look at certain gene variations and whether a BFRB will appear. But a correlation is not the same as causation. Correlation just means that 2 variables change in a similar way, which means that they could be a third thing that's affecting them both. But one variable might not be caused by another. So from that point of view, as far as the current research is concerned, we can't really say, although it is reasonable to presume, I would say that skin picking has maybe not a genetic cause, that would be, I think, a stretch, but certainly a significant component, simply because grooming is something that humans do and that other animals do, and we have genes that we've isolated that we know in one way or another play a role in grooming. And we also know that some animals, for example, will pick their skin or pluck their fur or feathers, or depending on the species. So we know that this exists in other animals as well. So because of this, we know that there probably is also a biological component, although what it is exactly, it's hard to say. And you will see when I go over some of the findings that we have for skin picking and hair pulling and OCD, why it's so hard to determine. Overall, when we talk about the OCD spectrum, we can say that what we notice, and this is in large part thanks to research for OCD specifically, that we have, that there are, let's say, different functional and sometimes structural issues in something that we call corticostriatal ways. So cortico usually refers in this case to the frontal cortex. Cortico obviously refers to the whole cortex, but I'm telling you now it's the frontal cortex, and something called the striatum. You can see it here on the picture. It's this area here. Striatum really comes from Latin. It just means, stria in Latin means like a channel or a line of some sorts. And the reason why it was named that way, is when they discovered these areas, early anatomists, they kind of would cut these slices in the brain, and then they would see all these little channels of white matter surrounded by gray matter. So that's why it's called that way. It doesn't really have any profound meaning other than that. But we know that, let me use this picture, it's less realistic and I think clearer. So somewhere from here, I hope you can see my pointer, from the frontal cortex, from prefrontal cortex to be precise, to the striatum, these connections sometimes don't quite work well in OCD. And it's somewhere here that we're supposed to look at the biological correlates, or perhaps even causes, as we might find out one day. So what is actually contained here? As you all know, the frontal cortex, prefrontal cortex specifically, is in charge of executive functions. So essentially what it does is decision-making, right? Or most of the things that you consciously decide to do, this is where it comes from. The striatum, this colored part here, consists of several structures. I will just outline them briefly for you in case you're interested, but I don't think there's a purpose in going into details. So this here, this structure here, is called the caudate nucleus. In Latin, it's called nucleus caudatus, and caudatus means something with a tail. So it actually means nucleus that has a tail, because you have a bunch of cells here, and then they extend like this as a tail. So that's why it's called nucleus caudatus, or the caudate nucleus. This part here is called the lentiform nucleus, and it has several parts. This inside is called the globus pallidus, which sounds very fancy, but actually just means a pale ball. So that essentially, I don't think there's any reason for us to go into neuroanatomy more than this. What you need to know about this area here is that, to an extent, it participates in cognitive functioning. But more importantly for us, it affects our motor function and planning, and also habit formation and reward. So conscious behavior, motor action, habit formation, and rewards. See how these two, kind of when you put them together, you almost get OCD. And so we have numerous studies when it comes to specifically OCD that show that there are sometimes even visible morphological changes. So some structures might have an altered shape, or some might be smaller, or some might be bigger. So that's what I mean by morphological changes. Although across different studies, these findings are not very consistent. So some studies will show that there are, other studies will not show that there are. However, when it comes to how these areas communicate, so when we talk about the functional studies, then we can see more consistent results, meaning that there are dysfunctions in this area. When it comes to body focused repetitive behaviors, theory that I've told you would suggest that something similar should be found with body focused repetitive behaviors as well, because they're also on the OCD spectrum, right? And this is one of the kind of the more common findings for OCD. Is this the case? Well, I think we can cautiously say that it is, although I really am very cautious, because what I'm about to tell you, I'm literally basing off of only a handful of studies, so we can't quite know for sure. For example, there is a study that I read that showed that the cortex, so the gray matter in the gray matter in the cortex, but on the right side, what you see here is the left side. On the right side, so on the other side of the brain, on the inferior frontal gyrus, which I think would be this part here. On the left side, you have a very important speech center here. It's called the Broca center. So not on the left side, but on the right side, that the right side seems to be thinner in some study subjects with trichotillomania. So hair pulling, also BFRB. What exactly is the meaning of this? It's really hard to say, but it is a part of the prefrontal cortex. So technically, this falls within what we know about the OCD spectrum. There were other studies that also took a look at people who struggle with skin picking as well. So one study, for example, found that certain parts of the striatum, so that this colored part inside, are hypoactive, so meaning they're less active than they would in someone who doesn't have a BFRB or OCD, quote unquote, normal controls, meaning that these parts kind of light up less. And also certain parts of the limbic system. I will show you that on a separate slide. So it appears to be a functional thing. Other studies have also shown that there are some functional, meaning it looks normal, it just doesn't function as it would in other people, right? When it comes to hair pulling, some studies have found volume reduction in the amygdala. You can't see them, I think, on this image, but maybe on the next one. Amygdala is a part of the limbic system. So we find a volume reduction. So the amygdala is smaller on the right side, once again. And then also smaller striatum, but on the opposite side. So on one side, smaller amygdala, and then on the other side, smaller striatum, right? This same study that found also something quite interesting, which is that some areas of the striatum, such as the caudate nucleus, are not bigger or smaller. Like their volume is overall not different, but they have certain morphometric differences. What this actually means is that it looks slightly different. The proportions maybe aren't identical to people who don't have a BFRB. So we have some findings that refer to the cortex, and then we also have some findings that refer to the striatum. As you can see, these are all very dispersed findings, and because BFRBs are so under-researched, most of these studies haven't really been replicated. So it's very hard to say if this is very consistent. But we can see that certain either different ways of functioning or even different structure in those areas that we find in OCD, we also find in BFRBs. So it is in a way justified to look at them as being in the same group of problems, so on the same spectrum, even if we see them as being separate entities. But as I said, this is really based what I just told you on maybe 3 or 4 studies. So we don't have a lot and we need a lot more. There was one interesting study that it took me a while to find, which talks about the differences between people who pick their skin versus people who pull their hair. This study didn't really come up with that much, but there were some interesting findings. So for example, those participants who had dermatillomania or who picked their skin had greater volume of the ventral striatum bilaterally Ventral striatum just means the anterior part. When it comes to the brain, we don't often use terms like anterior, posterior. We use ventral and rostral just to make things a little more complicated. So ventral striatum, these frontal parts on both sides, right? As opposed to people who pull their hair. So this is skin picking versus hair pulling. These areas seem to be bigger if you pick your skin, right? But they also showed reduced cortical thickness in the right hemisphere and in the frontal areas. They also showed certain other subcortical areas, but these are not as relevant. But my point is that obviously there are some differences, but when we look at these differences in and of themselves, they don't actually tell us much. And the study that I'm quoting, I think, had overall maybe like 35 participants, like 17 with I think hair pulling, and then 15 with skin picking, or vice versa. So this is not really a lot to go on. It is enough to tell us that they are different in some ways and in some people. So you can see how it's really difficult to generalize from these findings, but they are very encouraging in the sense that they do tell us that there is something that we can learn. We just need a lot more information so that we can extract something useful from there. We can say that there is there, but we just don't know what it means and how it can help us actually treat people better. One other very interesting finding from that same study is that those subjects that had trichotillomania, so that pulled their hair but didn't pick their skin, showed reduced thickness of the right parahippocampal gyrus, which is this part here. Since it's already labeled, I can't quite pretend to be all that, good at neuroanatomy, but it's labeled so you can see where it is, right? On the right side, so it had reduced thickness. And so I think this is a very good example to explain why is it that I say that these findings indicate that we need to do more research, but we can't really tell much from them. Because this area of the brain is actually in charge of something that maybe on the surface we wouldn't necessarily ever connect with either OCD, maybe with OCD, but not so much, I think, with BFRBs. And if we can, and this is really me speculating, so don't take it as serious science, but I will explain why. So what this area does is that it's in charge of remembering space. So if you remember a landscape, if you remember what a room looks like, parahippocampal gyrus is something that helps you with that. Also on the right inferior frontal gyrus does something similar. It has to do in part with space as well, and with some linguistic functions, although that's kind of less clearly defined. But the only thing that comes to my mind when I think about this is how some people don't think about picking until they go into their bathroom, and then they automatically pick. And however, this is reduced thickness in people who have hair pulling disorder. So I suppose that the same example could apply. That maybe the reason why we have these changes is not that these changes necessarily cause the behavior, but that they might reflect certain characteristics of the behavior. Because we know that basic principle in neuroscience, which is that neurons that fire together also wire together. And we know mainly from mindfulness studies, if you ask me, because that's where I learned about these findings from, which is that we have certain things that we can do that can actually alter our brain structure. We know that mindfulness can alter the morphology of our brains. We can measure the differences in brains of those people who meditate and those people who don't. And we also have studies that measure brains of people who start to meditate and then after a period of regular practice. And we can see that their brains have structurally changed. Because when a brain is used repetitively in a certain way, it will shape itself accordingly. The brain is very slow with its plasticity, but it's definitely there. It's kind of like muscles and going to the gym in that respect. So this is one way in which I propose that we understand this, although by no means do I think that that this is like the only explanation. And I haven't done any research. It's just what it occurred to me. Because sometimes when you read about these studies, you can find a lot of fascinating information, but you ultimately see that clinically there's not a lot that we can get from this, right? So the final difference that I want to emphasize, and then I will, I promise I will stop, it's the treatment. OCD responds to both pharmacotherapy and psychotherapy. There are dozens, hundreds, if not thousands of studies that show that SSRIs help with OCD. We also know that some other antipsychotic drugs, for example, can be used as an additional therapy to boost the effects of SSRIs, like risperidone or haloperidol, and we know that this works. So OCD responds to pharmacotherapy, but from what we can tell based on the studies, BFRBs don't really. So skin picking isn't really responsive to pharmacotherapy. In fact, FDA hasn't approved anything for body-focused repetitive behaviors, skin picking included. Several drugs have been tested in very small studies and sometimes in case reports. But what we can overall conclude is that psychotherapy seems to be far more effective. The most effective drugs of supplements, we have NAC or NAC, however you prefer to say it. So N-acetylcysteine, which is, I guess, a supplement. And even that only works in about 50% of those who take it. And studies use very high dosages and they select their subjects very carefully. So that's one reason also why we can't generalize the result. And SSRIs are about as effective that some studies say as placebo and not more. And in some studies, they actually have no effect whatsoever. So when it comes to treatment, there is a very big difference in terms that OCD responds to pharmacotherapy and psychotherapy, and you can combine both. Whereas when it comes to skin picking, psychotherapy seems to be far more superior as a form of treatment. This also tells us that even though structurally we can see some differences, it doesn't mean that they have the same underlying cause, right? Because both OCD and body-focused repetitive behaviors involve repetitive movements. Who's to say that neurons that, fire together didn't wire together to produce a similar effect in our findings? But it doesn't mean that that they're caused by the same thing. On the other hand, I also have to say that when you compare the number of studies that look at OCD and different forms of treatment and skin picking and different forms of treatment, it's not really something that can be easily compared. Right. So there are far more studies that pertain to OCD. So before we reach any final conclusions, we would really need a little more research. But currently, from what we can see, psychotherapy works better than medication for skin picking, whereas for OCD, both work. In terms of psychotherapy, for skin picking, different forms of treatment have been tested. The most tested one is habit reversal training, which is a behavioral intervention. And one of the reasons why it was tested the most is, first of all, because it was designed specifically for repetitive behaviors. And second of all, because it has a very clear set of steps and it's kind of time limited. So it's very easy to test. We know that other forms of therapy, such as acceptance and commitment therapy, some other forms of CBT also work. So other forms of therapy haven't been tested, but for all we know, they might as well be effective too. But overall, it seems to be something that is more amenable to psychotherapy. So I'm going to stop here. And since I've been going on for an hour, unfortunately, I will immediately stop and we won't have time for the Q&A. So here's my email here, and you have our support team. They would also be more than willing to answer any questions. You're more than welcome to email me. I've scheduled my Monday to respond to all the emails. Also, if you are not a member of SkinPick yet, but you're considering joining, you have a discount of $100 for your first month. You can use the coupon code below. So thank you very much. It's been a pleasure. Next month, you will meet Laura, and she will She will have a I don't want to reveal too much because I'm really curious how you will react to it, but it's going to be a very interesting webinar. And then who's going to do the webinar the month after? Keep an eye on your emails. Thank you very much and have a pleasant evening.